In the time we have here today, what I'd like to do is introduce sort of a bit of the work that we're doing, and see how it might fit into sort of the broader concepts of some of the generative AI for healthcare work that you all are focused on. In particular, I'm going to focus on this idea of cardiovascular digital twins that we're working towards, and really present the notion of wearable sensing as a domain that is probably lagging a little bit, especially in the remote settings, of helping us achieve the sort of intuitive and generative nature of our modeling for really creating end-to-end clinical pipelines. So just briefly, some disclosures that I've learned from our medical colleagues to present, here in terms of work that we're doing. So what I'm going to present here briefly is just sort of a clinical motivation, right? So a lot of the work that I do is integrative in terms of really coming from finding a real clinical problem first, then figuring out how to turn it into an engineering problem, then develop the methods that we're doing, and then talk a little bit about how the remote sensing and time series domain is sort of, in my opinion, lagging the other fields in terms of modeling, and how we can get to doing more advanced work and connecting these things together. So in brief, a lot of the work that we do is focused on the cardiovascular domain specifically. So in particular, one of the things that we look at are heart attacks and the complications that come before and after, in terms of the kind of monitoring that you need, the kind of interventions that are available to treat patients to prevent acute heart attacks, and then afterwards, what are the sort of post-event outcomes that happen in terms of just recovering from heart attacks or having heart failure or other sort of cardiovascular disease and burden that comes from there that tend to really limit long-term survival after that point. And the reason that this is a big focus is that despite the real focus on cardiovascular disorders within the country, the prevalence and rate of these sort of severe chronic conditions are just expected to continue going up. And so really looking at them afterwards isn't particularly helpful once they happen. What's really important is to look at how sort of underdiagnosed and undertreated they are as a preventative task. And to be able to do that, we need to be able to simulate the sort of progression of diseases over longitudinal windows. Now, the problem that we have with that is that clinically, a lot of the modeling work that gets done is usually used in sort of isolation, right? So you'll have models that run, for example, in an emergency room that evaluate that somebody did have a heart attack, and they can forward them onto the cath lab for evaluation, figure out where the blockages are, how to treat them, and such. But then models at the cath lab are sort of separated, right? They might be things that evaluate on ECGs to do diagnoses, and we've done some work on using ECGs and ECG tracings to try to diagnose hard to diagnose conditions, in particular earlier before they result in chronic and adverse conditions. But those don't get connected to then models that run during the operation, like things to look at bleeding rates and whether you need to prevent major bleeding while also trying to treat the heart attack, and dealing with sort of secondary outcomes, as clinical people put them, in relation to the primary sort of adverse outcome, which in a lot of cases is morbidity and mortality. And then even afterwards, have found that just simply a lot of the clinical models are very sort of linear average effects. But what you find when you start to really gather more and more data on people is that their risk tolerances are sort of really these nonlinear and very personalized kind of functions. So for example, one of the things that gets evaluated in the clinical context is how much contrast dye should you inject into somebody to be able to see where the blockages on the heart are. And the thought process has always been more contrast is good for imaging, but too much contrast is bad for your kidneys. And so there's just sort of a linear relationship there of how much they want to work on. But we did some work and showed that when you gather enough data and have enough of a sort of personalized representation of somebody, you find that some people are at high risk no matter what, some people are at low risk no matter what, and that there can be a really sort of personalized dosing here to help prevent chronic kidney issues as well as treat the primary cardiac issues. So what we would like to do is figure out how to link a bunch of these models together. So rather than think about model A, model B, model C, treatment A, treatment B, treatment C, how can we view this as sort of a continuous spectrum in which we represent a patient and we understand their course of treatment as well as decision-making that might happen at different points, both in the clinical setting as well as in the remote health setting, right? How can we measure what we need to do, see that there's potential for 2 or 3 different trajectories leading to, say, adverse events, and then considering the sort of treatments that can be provided for that person in that context to prevent some of those trajectories and move them to other ones. Now, the difficulty with this is in the clinical setting where we have a lot of data, we still need some more modeling, and we'll talk a little bit about the work we're doing there and the representation type of learning techniques that we can do to sort of understand what a person looks like, what their neighborhood looks like, and come up with sort of localized treatment suggestions. But in a remote setting, when you walk out the door and see how the next 6 months of you go, this side is significantly lagging with the lack of sensing developments, the lack of good data, and the lack of labels to allow us to sort of do any kind of continuous monitoring. And that ends up being a severe limitation that we're sort of looking to figure out how to bridge. So, when we talk about the clinical setting, there's a lot of interesting models, again, in the particular data domains that we can leverage and that we want to work with, right? There's a lot of work, for example, in language models, things like Clinical BERT, that are able to look at a variety of notes, a sequence of text things that happen, and linking them to sort of clinical data, structured data, to understand risks of significant outcomes, readmissions, and really understanding and processing unstructured data in a sort of embedded, represented way in the latent space. And so these are some things that can be worked on. And in fact, there have been some that have shown that if you can start to link it in a multimodal fashion, look at these notes data and think about them in sequences, and then look at them interleave with image data, that your encoding can now actually represent a more comprehensive representation of a specific patient, and as a result, a more comprehensive neighborhood around a patient. And then from there, you can make better decisions and have better predictions. And in fact, some of these models have even worked in sort of the remote settings to do signal translation, where a lot of these sort of representative models can look at a single signal domain, like an electrocardiogram that measures the heart function and the beating of the heart, and then something like a photoplethysmography sensor that would come off of something like a smartwatch, and figure out how to link them together. So whereas the smartwatch data doesn't necessarily have the labels or the clinical validity that an ECG would have, you can use these techniques to represent this data in the same way in the embedded space and translate from signal to signal. And now you can get full sort of ECG signal off of a smartwatch device in remote settings without needing heavy data logging burden. So, all of these, I think, are just a smattering, a taste of the available models that allow us to sort of represent patients, and then as a result, be able to generate forward-looking trajectories, treatment decisions, and represent simulations on these things. And these bases occur and exist, but when we talk about the limited setting in remote health, we're stuck with one specific problem, which is, even with respect to this amount of data, we need to be able to account for that data growth over time, right? So even the models that we have in clinical settings oftentimes are either structurally set to work within, say, a 48-hour time frame, or they're 24 hours of data and they slide forward in time and they lose notion of history, or they lose notion of earlier data as these things get compressed into smaller and smaller representations. So what we've looked at is first figuring out how to make some of these models flexible over time, using a meta-learning approach to sort of hide the fact that we have multiple models under the hood so that it looks like a single thing to a clinician, and then allow us to be able to grow the model across new data, whether that new data is new types of patients, new cohorts of patients, new data that's collected as you go from, say, an emergency room to an admitted lab and such, and how to make it look flexibly across these things. But if you can do that, we then hit the major limitation of what do you do when you walk out the door? So what we're going to focus on primarily today is a lot of our work on the wearable sensing domain. How do we take these sort of advances in these machine learning models and make them work in the remote setting to really look at longitudinal courses of care? And the biomarker that we're going to particularly look at is blood pressure. So blood pressure and hypertension, in which somebody has sustained elevated blood pressure, has been identified as sort of the primary intervenable marker for a lot of these cardiac conditions, right? As the blood pressure rises and then stays sustained, that causes arterial stiffness, it causes buildup, it causes plaque, which then leads to further downstream cardiovascular conditions. So if you can identify raises in blood pressure earlier and limit them, you can potentially intervene and change life course very, very early by simulating these different trajectories at a certain point, understanding if you're on a red path, blue path, or green path, as you see in the figure. Now, the problem is, the more that this is studied, the more we've realized that the signal acquisition is a limitation. So not only does hypertension matter, it turns out that nocturnal hypertension matters. So understanding what your blood pressure does when you fall asleep is the most critical element, one of the most critical elements. In fact, your system is supposed to sort of recover and relax at night when you go to bed, and seeing a reduction in your systolic blood pressure of at least 10 to 15%. Now, if we were in a room, I would have everybody raise hands, but think to yourself here, I guess in Zoom, how many of you have ever captured your blood pressure while you're asleep? And do you even know how you would do that? Right. And I can tell you that there's devices that can be used that are fit to you to capture it automatically, to understand your ambulatory and remote blood pressure, to understand what your real course of blood pressure looks like in real life, as opposed to something that might not be representative when it's captured in a doctor's office once every 6 months or once every year. But this means that this cuff will inflate every 30 minutes or every hour once you're asleep to try to capture what your blood pressure looks like while you're asleep. And a lot of thought there that, well, if it's disturbing you and waking you up, is it really a representation of if you're asleep or not? And more importantly, think to yourself, even if you understand critically that this matters, how many days in a row are you really willing to wear this? And how lucky or unlucky am I going to get in the one night of capture that I can possibly get? So with that, we've been looking at new sensing systems, again, either whether off of photoplethysmography sensors, off of existing smartwatches, or with our biomedical engineering colleagues, designing new sensors, in this case, impedance spectroscopy sensing, to try to capture surrogates of blood pressure, capture surrogates of the hemodynamic properties that we can measure easily, and then map it back to blood pressure. But critically, in a way in which we're not asking for labels from the user. We're trying to figure out how to represent data and then generate what we think would be signals that look like different blood pressures for a specific patient. So what we have designed here is something that needs to be flexible to different changes in pulse wave morphology. So if we use, for example, here, an arterial pressure waveform that would be captured in a hospital by sticking an A line into somebody's artery and measuring the actual arterial pressure waveform, we're going to get a varied sort of waveforms, as you see on the left there, A versus B versus C, which in the short term can be identified and classified as differences between patients that perhaps are healthier and patients that have severe sort of aortic stiffness and insufficiency. And on the right, you can look at continuous pulse waveforms and see potentially the difference between healthy subjects captured in remote and ambulatory environments and perhaps more elderly and critically ill patients that are captured in intensive care unit settings. But whereas each waveform itself can easily be classified individually, what's lost is this notion of representing what your signals should look like in your normal blood pressure ranges, and then how those changes to those signals either relate to changes in blood pressure or changes in your personal state, because both are possible and they confound models as they currently exist. So what we looked at is trying to leverage the sort of representation and pre-training techniques that have been sort of validated in electronic health record settings and tried to extend it now into this signal domain setting by developing these transformer-based models that can pre-train on a bunch of subjects. We give them a bunch of pressure waveform data and a bunch of PPG or bioimpedance data, and we tell them that these are the same people and these are the same beats, these are not the same beats, and we don't tell them anything else about the kinds of signals. But the idea here is to be able to simulate what your PPG signal would look like if your blood pressure were to spike. For example, your blood pressure, you might capture it in a doctor's office when you're normal, feeling fine, and then you come onto a Zoom call to give a presentation, and your adrenaline kicks up, your heart rate kicks up, your blood pressure goes up. But I've never captured that with my smartwatch and labeled it. So how would a model know, right? What I can do is I can take this kind of pre-trained technique and this sort of individualized representation, look at who my neighbors are, and as a result, I can start to generate what I think would look like different pressure waveforms for an individual. And what we've done is been able to show that if you can do that, you can actually map your outputted projection of the arterial pressure waveform significantly more accurately per subject than you can if you train these models from scratch and had access to labels, right? So using, for example, data mimic waveform data in which we do have the beat-to-beat labels, but masking some of those beats, it's just ultimately limiting to try to train a model from scratch to be able to do any of these individual tasks. The only hope we have is really to be able to pre-train sort of generalized representations, and then with limited labels and limited data, figure out how to generate what different samples look like at different spectrum. So high blood pressures, low blood pressures, and as a result, sort of be able to generate waveforms and then see how well those match the realistic waveforms. And by doing that, we can actually match the pressure waveform and the systolic peaks at the top and diastolic peaks at the bottom, as well as the dicrotic notch in the middle, in which you're switching from your systolic phase of beating your heart to the diastolic phase where your heart's relaxing and you're getting a little bit of reflection in your arteries. And by doing this, we can start to measure through very non-invasive and simple to capture techniques, invasive measurements like blood pressure, as well as the full waveform to understand the potential for measuring arterial stiffness. And by representing that, we're actually allowing ourselves to then do a secondary phase in an unsupervised setting of simulating a whole range of signals and automatically rejecting ones that look noisy. Because at the end of the day, our hypothesis is that you can't replace all clinicians in all settings. You're not going to be able to measure all these things automatically, diagnose automatically, and manage and treat all remotely. But what you can probably do is have, with high confidence, a bucket of data that looks normal, with high confidence, a bucket of data that looks abnormal and requires attention, and realistically, probably a bucket of data in the middle that's highly uncertain and just says that this is something that you probably need to follow up with a clinician and get a more accurate measurement with a more validated device. And by doing this, we can, again, look at what our signals look like, generate what we think other signals should look like, and when we capture them, look at the distance in the embedded latent space and automatically reject ones that we think are highly uncertain. And by doing that, we actually get a much better correlation at predicting your systolic and diastolic blood pressure. But more importantly, not only do we get more accurate cuffless blood pressure estimates, but as we see in the table here, we get significantly reduced standard deviations. And that's sort of one of the things that we've been pushing beyond sort of what a lot of the other models have shown, which is that in cross-validation and iteration and random resampling and shuffling of all these things, what we find is that we can get a more representative space of what your entire patient data would probably look like with limited labels versus training a bunch of these techniques from scratch and what is and isn't included in terms of training data and noise. So in particular, we think that this is sort of an ability for us to do remote diagnoses and remote monitoring, at least with reasonable confidence, but only through the ability to pre-train and represent data across clinical domains and then back into the remote health domain. And so by doing that, then it allows us to say, all right, if we can capture all that data, how do we really connect all of these to make everything look at like one seamless representation? So if I can capture this data, and we have to some extent shown this with our clinical colleagues at Yale, shown that with this ability to capture this representation at any given point, I can look at what somebody looks like, represent what the diagnostic test would provide, even if I haven't had it with the remote data, look at somebody's neighborhood of who looks similar to them, and as a result, look at the other individual's trajectories as a first pass simulation of what is likely to happen to you with or without a certain treatment. And I can look at how you might change in neighborhoods and how that treatment effect might change. So really move away from sort of average treatment effects as clinical trials run them and really start thinking about localized treatment effects by looking at local patients and seeing what their outcomes were as a first pass to simulating before getting to the real digital twin area of being able to simulate you with your data, with your possible trajectories. And by looking at all of these, I can repeat this and get some level of robustness and confidence in what I'm doing. And from that, I can provide even clinical sort of hazard ratios over using or not using certain tests, using or not using certain diagnoses, having or not having certain treatments, and have started sort of looking at these with a remote sensing system, particularly ECG focused in evaluating potential remote health as a sort of surrogate to and precursor to clinical modeling and clinical health conditions. And if we can do that, the final step then we have is how do we link them back together? Because what ends up happening is if we can realize the remote health data domain, we're now going to have a situation in which any clinical visit that may be on the order of days is going to have a precursor of potentially 6 to 12 months of clinical data, or of remote health data. But even within the clinical visit of 3 or 4 days, we have the same sort of domain scaling issue here, where some time series data is going to be on a beat-to-beat nature and be highly frequent and highly dense, and some data is going to be extremely sparse, like notes, right? So if I have a note that represents a patient visit and a patient examination, and that examination might summarize what was a sequence of labs that happened or a sequence of tests that happened over a period of time. And I really can't think of that as a static piece of data and a static piece of time. What I would like to do is break everything up and consider everything, even individually, a single lab that nobody else has, a single note that nobody else has, or a single image that's taken, and think of it actually, everything is a time series data, but just with irregular sampling, with very low frequency sampling, and look at how I can break up embeddings of, say, text models and text embeddings, not as an entire note as a single embedding, but as sub portions of notes aligned with sub portions of time series data. And by doing this sort of pre-trained masked alignment, I can represent everything in multimodal domains as time series data. And by doing that, I can actually, with less data, again, increase predictions of adverse events. And we can match sort of baseline ICU outcomes here. Again, this is primarily trained off of Mimic because of the availability of the data, but I can match sort of benchmark models that are trained on the full data and full sets with minimal labeling. So I can represent a bunch of different data and not necessarily need all the notes or not necessarily need all of the time series data, and make a model that's robust to some features that I might have and some features that you might have, by finding what features are aligned and what features are similar and dissimilar, and represent all of my data across all of these domains, multimodal domains, as time series. And if I can do that, I can really start to think about then how do I generate new modeling techniques to understand frequently changing time series data that is irregularly sampled. Some things that are extremely frequent, some things that are extremely infrequent at different rates. So they will result in different tokenization problems with standard transformers. So what we're looking at is saying, well, how do I then actually make a model that's robust to real-time changes and provide real-time hazards? And what I can really think about is that time series values themselves have different risk properties and different risk thresholds at different times, right? If I come into an emergency room and have really high blood pressure after a heart attack, maybe that's not a problem unless it's extremely high. But as I'm treated over the next few days, I would expect to also see that blood pressure come down. So a blood pressure at a certain value might not be extremely critical on day 1, but will be extremely critical if by day 4 you haven't treated it. So by looking at time itself as a feature here, we can really sort of subdivide the space of features and the values in which they may or may not present risk, along with time, and at what time having different thresholds and different values. And if we can sequence the time grid up, we can look at each of these things as sort of piecewise constant in each sort of little sub-frequent, frequent time split, and look at the different potential risks, the different sort of hazards that come out of it at any given point in time and at any given point in change in a feature. So any time change, any feature change, I can sort of look at these in parallel and start to get any kind of risk change. And as a result, I can really take everything that we've done, saying, assuming we can capture all of this data over time, I can take my fully representative embedded nature of data of a patient, and for every piece of data that comes in and changes this representation, I can also generate a real-time hazard estimation. And then I can build treatment risk models and then treatment models off of that and get a sense of this sort of continuous representation of what you are, what your risk looks like, and as a result, what your trajectories will look like. And so with that, we would hope to be able to realize this idea of this continuous state space modeling. So how do we represent people and generate these patient trajectories without needing the label burden, right? And so leveraging a lot of the representation learning techniques, the contrastive learning techniques that create these embedded settings in which I can look at a person and their localized neighborhood and have this distance in the embedded space mean something for what unseen data might look like, to get a real-time estimate of what's happening to you continually as I capture data in clinical settings or in remote health settings. And And I know that that's sort of a high level smattering of sort of 3 different key contributions in clinic, out of clinic, and linking them together. But that's sort of the initial phase of where we think we're at in terms of being able to really realize continuous modeling for patients. And so happy to dive into any of these in particular and in more detail, but briefly would like to acknowledge the sort of large team that needs to be included in all of these things, clinicians at the ground level to help come up with the problems, meeting weekly, constantly talking to each other, and then obviously the students who do a lot of the great work. And with that, hopefully, I can open up for questions. And again, I know that it's sort of a jump through topics and maybe not a deep dive in any of them. I'm happy to go through any of them individually, or my hope is potentially even offline and talk to you all more about the opportunities that you have at your center and that we have at our data and with our colleagues also over at Yale. And with that, I'm happy to open it up for questions.
Thank you very much, Bobak. It's a great talk. Yes, I think there's a lot of interesting things. I work with Dell Children's Hospital. They have also this wave data, and we try to figure out the early blood clock by looking at this wave data. Happy to chat more. But time-wise, let's, any other question from audience? Okay, I have one question. So so you develop a new device that can constant measure blood pressure, right? So it's a wave data. Then you use that to build a digital twin to say that's actually so you say blood pressure is the major indicator for cardio attack, right?
Well, so there was a thought process. There was a Lancet commission a few years ago that suggested that while there are a number of things that can be significant triggers in the acute setting, blood pressure and hypertension seems to be a precursor for most of them. So if you can stop the hypertension, you can stop then the atherosclerotic buildup and things like that lead to the actual heart attack.
So I was wondering, is your sensor can also measure more than BP? Because since they are varying on the West, you might can sense other things, right?
Absolutely. And this is where we're sort of hoping to go, right? And this is where a lot of things like the All of Us data set might help us well. But the thought process is right now, let's give a measure that clinicians know what to do with. And as these things get used and deployed and evaluated, it's highly likely, our hope and our hypothesis is that we could actually even potentially remove blood pressure as a marker altogether, that understanding the full waveform, the way the waveform changes, and how it reacts to all kinds of contextual environments is probably going to be much more telling than a systolic reading once a morning, a diastolic reading once a morning. But sort of stepwise trying to get there, because even this proposal, when we started it, got immediate pushback from clinicians saying, well, we don't need more than the 24 hours of data of blood pressure. And more importantly, we don't know what to do with that much data. So trying to sort of slowly step our way towards that. But that's exactly what we think, is that we can measure all kinds of hemodynamic properties, fluid properties, and all kinds of pulsatile characteristics.
Great. Okay, time-wise, thank you, Bobak. Thank you very much. And oh, Steve has a question. Sorry, Steve, please.
Yeah, just a quick one. I noticed in your bland Altman of the diastolic blood pressure, it looked like there was a little bit of bias. Do you think there's opportunities to like do more post-processing or improve the